Hi, good evening, everyone. This is Dr.N.H. Krishna, CCI founder, chairman, trustee from Davangere. And what a panel, man. You tell me. Look at those faces, look at those names. Dr. Raja Dhar from Kolkata. And you understand that we are covering the entire India in every corner when I go ahead telling you. So, Dr. Raja Dhar, the Raja of Indian Pulmonology. Namaste, boss. Welcome. So, he is here. And we also have from Mumbai, the dashing Agam Vora, the most dashing
Oh,
pulmonologist in India.
hi.
welcome, Agam. And
Thanks.
the Einstein of Indian pulmonology is right here, Dr. Murali Mohan, sir. Namaste. uh, Dr. Vijaykumar Chennamchetty, our CCA webinar coordinator, a young and energetic person who has been doing a lot of activities for CCA all this time. He's here. Welcome, Vijay.
Namaste, Anna.
Yes. Surya Kant, sir will be joining us in a short while. And this is important, as you all are aware regarding the topic. Now, initially, Raja will give a presentation for around 10 minutes, followed by which there will be a panel discussion amongst the panelists. Then we will also take the Q&A from the audience. Dr. Raja Dhar, the stage is yours. Please go ahead.
Thank you, Krishna Bhai. Absolute pleasure to be a part of this meeting. Like I said, it's a pleasure to be a part of such an elite panel. And Krishna Bhai, you don't need any introduction, but if I'm the Raja of Indian Pulmonology, you have put together CCI, which represents pulmonology in the country today. So well done. And my congratulations to you, to Vijay and the rest of the CCI team for having come together as such a vibrant society. So what I'm going to do over the next 10 minutes, thank you. What I'm going to do over the next 10 minutes is to talk about inhaled corticosteroids and COVID-19. I just want to set the stage. There's a lot of points that I'm going to talk about, which are going to be discussed later on as a part of the panel. But this is just to set a platform, and I'll hurry through the slides so that I can finish in 10 minutes, and we'll revise things when we do the actual meeting. So this takes us back about a year. And this is one of the first publications that came out in the New York Times and was published later on in Lancet Respiratory, which looked at comorbidities in about 1,600 odd patients in China. And they looked at the various comorbidities individually and found that diabetes, hypertension, malignancies of various descriptions, all of these comorbidities resulted in increased risk of COVID-19. You can see COPD also on that list, and we'll come back and discuss about COPD as we go along. There's been a lot of controversy as to whether COPD is indeed a risk factor for COVID-19 or not. However, what is important on that in this study is the fact that asthma does not feature on that list at all. The possible hypothesis for this was that maybe chronic respiratory disease is not recognized in COVID-19. So when you reach an emergency, your cough, your wheeze, your breathlessness, whether it's a part of the COVID syndrome or whether it's a part of the background chronic lung disease is something cannot be understood, is what they hypothesized. They also said that therapies used by patients with chronic respiratory disease might be reducing infection. So there you're alluding to the inhaled corticosteroids. This paper also alluded to the long-acting beta agonists that are used in these patients. And again, we'll come back to this as a part of this presentation and later in the panel discussion. Similar sort of time, there was this paper which came out in Yaki, which again looked at a smaller number of patients, but looked at risk factors. The first one was increased incidence of COVID-19. This looked at severity and mortality in COVID-19 and comorbidities. And here you can see both COPD and asthma has been featured. However, the percentage of patients who get severe disease with the background of asthma was low. The other culprits that you all know about, the hypertension, the diabetes, TB also feature. But the important part is the hypothesis that they came to was that the prevalence of asthma in COVID-19 was less than 1%. And it was speculated that Th2 immune response in asthma patients could counter the inflammatory factors of COVID-19. So compare this with BCG vaccination. There was a similar paper which came out in Yaki at the same time, which said that the Asian continent and especially India had BCG vaccination, which increased the Th2 immune response and hence protected against TB. The asthma hypothesis is similar to the TB hypothesis and is also important to remember. This is coming forward another year. So this is about 6 weeks old, which looked at the risk of COVID-19 hospitalization in patients with airways narrowing. So be it asthma and COPD, and the benefit of corticosteroids. And they showed that with both asthma and COPD, the risk of hospitalization with COVID-19 was lower. So remember, here we're not talking just about asthma. We are also talking about COPD. And their hypothesis, which is in line with what we are discussing today, was this reduced hospitalization was actually related to inhaled corticosteroid protecting against viral replication and reducing viral replication. Let me take you through a couple of basic papers next. So this is in vitro data, which shows the role of inhaled corticosteroid ciclesonide in reducing and inhibiting SARS-CoV-2 replication. And I won't labor this point, but here you can see on my pointer are various drugs that have been looked at to reduce SARS-CoV-2 RNA in the cell. So lower the amount of RNA, the greater the inhibition of SARS-CoV-2 replication. And you can see ciclesonide on there. You can see the effect of fluticasone is dubious. However, with ciclesonide, the number of RNA copies is reduced significantly. A similar effect is found even with mometasone. So that's an effect. The inhaled corticosteroids, some inhaled corticosteroids seem to have an antiviral effect by reducing viral replication. This is another paper which talks about ciclesonide blocking, next slide, yeah. So this is looking at inhaled corticosteroid, downregulating the ACE2 receptors in COPD. And again, this looks at the healthy airway, then the COPD airway, and the fact that the inhaled corticosteroid there on my pointer actually causes suppression of type 1 interferon and hence suppression of the ACE2 receptor site on the cell. So ACE2 receptor site getting suppressed by inhaled corticosteroid, hence reducing the replication of the virus. This is a lovely paper which is now published, came from Dave Singh's group. And I want you to hold this thought. This slide is important because it forms the fulcrum of the entire panel discussion that we'll have today. So this looks at patients who are previously healthy or patients with chronic lung disease who are infected by SARS-CoV-2. If you're asymptomatic or mild symptoms, more than 95% of these people will recover. However, in patients who are previously healthy and more so in patients with chronic lung disease, if you develop a cough and fever and you start the inhaled corticosteroid early in the disease course, so you can see this cartoon depicts starting at day 2, you're going to reduce the dyspnea and the pulmonary infiltrates that happen later on in the disease course. And that's the thought process that needs to remain when we talk about inhaled corticosteroids in COVID-19. Can inhaled corticosteroids reduce morbidity due to COVID if initiated early in the course of the disease is the question that we are asking. And the study in question here is the STOIC study. The steroids in COVID study. We're doing a similar study in India and the results will be out in the not so distant future. But that's a different story altogether. So this is coming from Sanjay Ramakrishna and Mona Bafadil group in Oxford. The study scope was to study the role of inhaled corticosteroid in COVID-19. And the aim was to demonstrate a reduction in severe illness from COVID-19 using ICS at the onset of COVID-19 symptom. And I want you to remember, onset is important, early use is important. And the other secondary aims are looking at immune response to derive a mathematical model for ICS intervention for mechanistic insight in challenges in altering the trajectory of the disease. That's a full worded nomenclature. Basically, all it means is whether it alters the trajectory of the disease and reduces severity is something that we are trying to see, and to investigate COVID-19 infection rates in patients already on OCS and compare this with seasonal flu. So this was a community study, adults above 18, within 7 days of onset of disease. Symptoms are cough, fever, and loss of smell in these patients. And the two arms are usual care plus budesonide at 800 micrograms twice a day. And this is worth remembering, 800 micrograms twice a day versus usual care. The things that you monitor are temperature, saturation, symptom diary. you do a throat and a nasal swab, and you look at serology testing for antibodies. So the primary endpoint, which is the important one for all of us to remember, is reduction of urgent care visits and emergency hospital visits. The secondary visit endpoints are clinical recovery, symptoms, body temperature, etc. The baseline demography in these patients is similar. And the important thing here, which I want to highlight, is the reduction of urgent care visits, emergency department assessment and hospitalization, relative risk reduction by a whopping 91%. There is actually no drug in COVID, in mild COVID disease till date, which has resulted in a relative risk reduction of a similar magnitude. We then look at other endpoints. This is self-reported out clinical recovery, and I'll be quick with this. Again, the days to clinical recovery seems to be shortened by 3 days in the arm using budesonide as compared to the arm without budesonide. So reduction of recovery time by 3 days is something that we see. What about symptoms? This is one questionnaire, the common cold questionnaire. The symptom burden in favor of budesonide. So reduction of symptoms with budesonide. Mean temperature seems to be reduced in the budesonide arm, and the oxygen saturation seems to not to be altered in patients with budesonide versus not on budesonide. So saturations are not impacted. The other thing which is not impacted is the viral load. So we don't know why. We would have thought that viral replication would be reduced. However, in the STOIC 1 study that I'm quoting, viral replication was not altered. So reduction of symptoms, reduction of reduction of duration of disease, most importantly, reduction of hospitalization and emergency visits, but no reduction in viral load. So that's the summary of the STOIC study. I won't read through this. We have discussed it all. The other study which I mentioned in passing is the principal study, which looked at the effectiveness on the use of budesonide in COVID-19 again. And the endpoint here was the time to first reported recovery, defined as the first instant that a participant reports following the recovery, and hospitalization or death from COVID-19. And again, the interim analysis showed a reduction of 3 days in people with COVID-19 with risk factors and adverse outcome. So the STOIC study, I mentioned wrongly as 3 days. The duration of disease were reduced by 1 day, whereas the principal study resulted in duration of disease being shortened by 3 days. So sometime between 1 to 3 is the reduction of duration of the disease. This is the guideline given by AIMS. A guideline has come out even from ICMR thereafter, which talks about inhaled budesonide at a dose of 800 micrograms BD for 5 to 7 days if symptoms are persistent beyond 5 days of disease onset. The ICMR has rightly modified this to earlier on in the disease onset. So start early is something that they are advocating. But I guess using this drug is useful is something that we all agree. So that's all that I had to say. Let's get back to the crucial part of the meeting, which is the panel discussion now. And if we can have your videos on, please. Thank you very much. Hello, Dr. Surya Kant. Welcome. Good to see you.
Hello, sir.
Hello, everybody. Nice to see you again.
So we'll start off with the questions and
First
answers.
of all,
yeah,
Raja,
yeah,
I must tell you it is fantastic study, and I'm so happy something new has come up. Krishna, everybody calls up saying that sir, Favipiravir we've already taken. We've already taken vitamin C and vitamin zinc. We've already taken steroid. Abhi kya karna hai? What else? And you have nothing else to tell them. At least you have something else to tell them. You start a inhaler. You know, I mean, for them, for inhaler, I think they will for sure contact us. So thanks, Raja, for bringing out this study.
Thanks, Agam. And the other important thing is that maybe the compliance to inhalational therapy, even for chronic respiratory disease going forward, would get better. Because
may improve
the psyche of people. I mean, you often say, I've always heard you saying, Agam, that you've never seen anyone declining any treatment in COVID. So inhalers hopefully will also become a part of the human psyche. So I'll start off with Krishna Bhai. So Krishna Bhai, I wanted to ask you, often these patients with mild COVID, right, or even very mild COVID or asymptomatic COVID, you wonder whether it's worth treating these patients in the first place, because more than 80% of patients would recover anyway, and they would remain mild or asymptomatic or very mild. So these drugs, so be that inhaled budesonide, be that favipiravir, be that even your ivermectin, are used for this category of patients. So do you think it's worth use of resources to treat these individuals? Or do you think just observing them, maintaining saturations, looking at temperature, etc., is enough for these patients? Krishna Bhai, you're on mute.
See, this is my slide for everyone. Gold price changes every day. Petrol diesel price changes every week. And treatment guidelines for COVID-19 change whenever. Hence, I make an oath here that opinions I deliver today are correct as per my best of knowledge at this present panel discussion on this date only. And I am not at all responsible from tomorrow to what I stated today.
So make it a general disclaimer from all our.
Yes.
Yes, it's a general disclaimer now.
And he's a leader. Whatever he says, we have to follow.
So Krishna Bhai, I'll borrow this slide from you for all my COVID talks from today.
Oh, please, you are permitted, and everyone, I think, basically should do this.
Can I add, just like petrol prices keep rising, the number of treatments for COVID also keep rising every year.
Yes. So I will take that question now from your side, Raja Bhai. Basically, I feel when the patient comes to you, the basic thing is you should write something to him. You cannot send him home. Everybody expects that he writes something to us, and it could be even zinc or vitamin C or D3 or even a placebo also. The patient's psychological confidence will boost up when you write something. So if anybody comes to you with a COVID positive report, even if it is mild or moderate, I suggest, may not be clinically or may not be medically, but psychologically it will help them a lot. So you can start with ivermectin, or you can start with zinc, vitamin C, D3, or you can start with favipiravir of your choice, or anything of that. But please do not send them back empty-handed, because they will definitely go to someone else, and someone else will write something to them. And writing something, your words of assurance to him, and he is going back with something in his hand, it is very important. So I feel even mild or moderate people who could go along well, who are basically asymptomatic, should also be given something while they go. And this is the reason what I described now.
Sure. So Krishna Bhai, point well taken. And I think this stands true for any disease. So if a patient comes to you, they are seeking help, and if you send them back empty-handed, it's going to disillusion them to an extent. So that point is well taken. If I can just pursue this question a bit further. So aside from that, you know the favipiravir data. There's data that we have just discussed from STOY. So we are talking about reduction of duration of disease, reduction of hospital visits and emergency visits. So starting the drug early will probably also prevent the disease from moving from milder grade to a more severe grade, people going into the emergency department, and also from the patients losing a greater number of days unwell. So I think that's also an important point.
Completely agree. Yeah, definitely. Agree with this. Completely.
Okay. So I'll come to Murali next. So Murali, I have a difficult question for you. So, there's various treatments that have come over, like you said, petrol prices versus COVID drugs. We have had a multitude of drugs, the erythromycin, the doxycycline, the ivermectin, the favipiravir, the inhaled budesonide, and all of these are repurposed drugs. The evidence for these are soft evidence and often used without evidence. So when you prescribe for people with mild or very mild or moderate disease, do you actually have sub-classification of patients? Do you phenotype patients? Do you say, okay, this is the patient where I would prescribe the ivermectin. This is the patient I would give favipiravir. This is the patient I would give colchicine. This is the patient I would give inhaled budesonide. Or would you rather use a combination of drugs? What's your approach? What would you advise people to do?
So as you said, that's a difficult thing to answer. The first thing is, does the patient really need any treatment? I just this evening got a call from a colleague, a former student and colleague who's having his COVID for the second time. The very first time he got away with virtually nothing. He's been vaccinated, and I suggested to him, he's a senior physician. I've suggested to him that he doesn't need to take any treatment. If he really wants to take something, it's up to him to take, ivermectin, doxycycline. But my own suspicion is he doesn't need it at all. I think we are adding one more drug to the mix, Regeneron, which is in the pipeline. It's going to come in. So, and that's used in mild disease. So this throws up this question even more importantly. Ivermectin is cheap. Doxycycline is cheap. I mean, you can get away with this particular treatment for perhaps something like 50 to 60 rupees a day. But Regeneron is not going to be inexpensive. It is going to be pretty expensive. That's a very difficult decision you're going to have to make. So I think we have to go back to what are the risk factors. So if I find a person with multiple risk factors, age being one of them, an obese patient, multiple comorbidities, then I think it's just safe, who's never been vaccinated. That's the kind of person I feel a little more uncomfortable sending away without any treatment. And then I make them the offer of, you can take this treatment. This seems to have some effect. There is some evidence, though it's not very strong. But this is what we usually prescribe, and you can take this. And for all mild disease, I believe using the mildest, least harmful medication. In my opinion, that does not include favipiravir. I don't remember ever having prescribed favipiravir. So it's generally one of these small, Agam is looking very shocked at me.
So come to Agam with the same question in a minute only, but let's hear your take. Yes.
For me, I think it's a question of whom do I prescribe it to for the mildest disease. And I just had my friend ring me up. He and his wife have not taken any treatment. They've done fine. They're on day 12 now. Absolutely nothing they've taken, and they're perfectly well. So I agree with you. 80 to 85% of people will do well without any treatment. That's the nature of the beast. The 15% who are going to progress are the ones we worry about. And
I think we lost Murali for a minute.
but I'm willing.
Murali, we lost you for 10 seconds in between. So if you can just repeat what you said, we lost you for 10 seconds.
Yeah. So basically I said to identify this 15%, we're going to have to go back into the history. And that history is, what are the risk factors? Now, the great worry for me, Raja, is that these risk factors and phenotypes are changing in the second wave. And that's the big problem. The lessons we learned in the first wave do not apply in the second wave. We're seeing younger people, we're seeing people without comorbidities, and they are going into the severe thing. So I think we have to revise this. I've just asked our team to look at what seem to be the differences between the first and the second wave, and hopefully we'll have an answer in about 10 to 12 days.
Right. Hopefully before the third wave.
So I'll come to you, Agam. Agam, I know.
I'll come back to the phenotype issue later, Raja, because I think,
Sure. So I'll come back to you, Agam, quickly, and maybe I saw Dr. Surya Kant's hand too, so I'll come to him after that. So I know that you are someone who prescribes quite a bit of favipiravir. You prescribe quite a bit of ivermectin. I know you would probably prescribe quite a bit of the inhaled budesonide too. So if you wanted to compartmentalize, or if you wanted to suggest a prescription for someone who is, say, 55, not many comorbidities, a low-grade fever, a dry cough, and a little bit of allergic rhinitis, what prescription would you give this 55-year-old with no comorbidities from the list that we have just spoken about a little while ago?
So that's a typical situation. In extension to what Dr. Murali Mohan said, I also like to look at the risk factors. So you have somebody who's probably mildly symptomatic patient with the risk factor that he mentioned. There you have obesity and associated diabetes, hypertension, which are not well controlled, and patient who's more symptomatic. Now, I do not know whether if you don't treat this mild patient, mild would progress to moderate or moderate would progress to severe. You have some patient who just remain mild. So you have some patient whom you treat, still they keep on worsening. And you have classically what I was looking at is the cytokine storm phase, which is coming up after 7 or 8 days. Now I'm seeing after 9 and 10 days in the second wave. Actually, 9th day is supposed to be the most difficult day, at least in Mumbai, in my limited experience. And I'm seeing, Raja, couple of phenotypes, I'm seeing some patients who are presenting with viremic and cytokine phase together. I'm seeing some patients who are presenting with early viremic phase and then coming up as a late, cytokine phase. And we are seeing some patients who don't have viremic phase at all. They directly present with cytokine phase. We have some patients who have only viremic phase. They don't develop cytokine phase at all. So there are different presentations which are coming, and it is very important for us to understand what kind of presentation is this? So when you have a patient whose CT score, say if you have done, is about 5 by 25, who have patient who just presents to you on first day, and his cough is disproportionate to probably what you expect on CT scan, probably that is the time to do their inflammatory markers as well. And you may be surprised to know that this patient is presented with both. So what I do is I will try to put patients on no treatment, provided patient understands what I'm doing. You have a young patient who's a techno guy who's reading daily WhatsApp is and well aware of treatment options and is okay with that decision. I would put him on nothing, but put him on zinc and vitamin C, and as Krishna said, would give him some prescription. And then I will have a second category of patient where I'm not smelling problem. When I look at them, they're otherwise healthy and hearty, and then I will put them on doxy-ivermectin combination. And whenever I see a patient who's got some risk factors or who had, say, a family member who deteriorated fast and kind of a situation, I would put them on favipiravir. Now, I know Dr. Murali Mohan does not like favipiravir, and so many guidelines probably did not mention about favipiravir, but I have a soft corner for it. And I am of the opinion that during pandemic time, even 1 day of fever and your clinical suspicion is, COVID, you must put them on treatment. And if you put them on treatment like this, they do well. So that's my take on it. So what you said is about 55 years old male patient with cough and this presents. My options would be either I would put him on doxy-ivermectin combination and I would put him on inhaled budesonide, or I would put this patient on steroids, low dose steroids to begin with, if I feel this patient is in early cytokine phase. That's my take on it.
And you wouldn't combine drugs, Agam, and I'll maybe ask the same question again to Murali in a minute, but sort of his thoughts on what you said. But would you actually combine things? So ivermectin and favipiravir, for instance, or would you never do that?
Not really. I have not felt the need. Again, in my limited experience, I have not felt the need. So I've stuck to this combinations. I'm very happy. When I'm using doxycycline and ivermectin, this goes in combination, or only zinc, vitamin C, etc. And when I'm using favipiravir, I think I don't need to give them anything else. Favipiravir otherwise is a strong drug, provided started early in the course. And what I do is I put them on day one on favipiravir, and if I feel I've taken a wrong decision, I don't mind stopping it. I would like what we do is trial of treatment. We've been doing it, for a number of years. Once you feel your decision was wrong, you can stop that TB treatment. Similarly, here in COVID, I put them on favipiravir. On day 2, day 3, I think I have taken a wrong decision. I stop favipiravir at that stage. That is what I do.
Sure.
Thanks.
Sure. So I think one important thing that you highlight, Agam, and I think this is something which is worth the audience taking home, is whatever drug you want to start in mild COVID, please start it early. Don't wait for the disease to worsen. This is true even for sort of moderate going into severe disease. Unless you start the drug early enough, it's not going to work for you. We learned this the hard way, even with remdesivir, even with steroids. And I think we are learning the same about these early COVID drugs. So Murali, a quick thought from you about what Agam said, and then we'll go to Dr. Surya Kant with his thoughts. Murali.
I completely agree with what Agam said in terms of, we are seeing those different phenotypes. We are seeing the younger people, and some of them progress really fast. And that's the big worry for us. What my argument is, if I'm seeing a person not responding to the initial ivermectin doxy, or they're not on treatment at all and they're rapidly worsening, I don't want to wait by giving them favipiravir. We go straight into remdesivir, which we have much better, results with. And remdes certainly seems to make a big difference in the first 2 or 3 days that you give it. Worryingly, we are not seeing this in the second wave. In the first wave, we were seeing very good responses to remdes, apparently not seeing as good a response to it in the second wave. But we are seeing responses. So rather than waste time trying favipiravir, which in my opinion has produced a lot of GI symptoms, you're using up another 2 or 3 valuable days. As you emphasized, early treatment is the key. I'd rather use something which has slightly greater evidence. My colleague from Bangalore, Dr. Ravindra Mehta, showed fairly clearly that if you start remdes in the first 9 days, you get very good outcomes. If you wait and start it after that, you get worse outcomes. Obviously, this 9 days is a moving goalpost. Sometimes 9 days is too late. So I'd prefer to start it early. Between 5 and 7 days is the latest I would want to start an antiviral. You brought out an important point that budesonide does not reduce the viral load. Okay, so when you're starting budesonide, and nowadays we are starting it very early, I would want some kind of antiviral with that. So that is the big worry for me. Are we missing out on those valuable days by trying the intermediate favipiravir? Otherwise, I completely agree with what Agam said. Everything he said is what we practice.
So I think to go along with what you said, Murli, it's important even with the favipiravir to start it early enough. Often what we do is wait for symptoms to progress, the patient to spike high temperatures, become more unwell, and then start the favipiravir, which becomes a challenge. Dr. Surya Kant, a quick comment for you. I'll ask Vijay after that if he has a comment to add, and then we'll move on to the next question. Dr. Surya Kant.
You see, Dr. Raja, initially, of course, in the beginning, 2020, I think Uttar Pradesh was the first government in India which, of course, issued our own geo for the combination of ivermectin and doxycycline. And of course, luckily, I was the expert, external expert in that group. So I think the UP government is providing free of cost drugs, means ivermectin, doxycycline for 5 days, and of course the other vitamins, zinc, and everything, to all patients who were kept in the home isolation. That is the all mild cases or asymptomatic cases. So this is the usual protocol which we follow for first 5 days. Now, after 5 days, there may be 4 types of courses. Number 1, maybe recovery. That is the first, which we want. Second, fever is persisting. Third, dyspnea is worsening and saturation is going down. And fourth, both fever and of course dyspnea. So these are the 4 outcomes. Now we go one by one. If the patient has recovered, yes, it's okay, fine. So the COVID control room will call, are you fine? Yes, fine. Then thank you very much. You continue with the steam inhalation and some kind of vitamins. And of course, you maintain your isolation for the remaining days. So that is the COVID control communication from our, of course, CMO office. The second option where
can I ask you a question about point number 1? I'm sorry to stop you. So would the COVID control team in this first category ring a second time, or is it just the day 5 phone call? Because
no. They continue to follow till the whole isolation period.
Okay.
The whole isolation period, because there are certain patients they develop after 4-5 days, after 9 days, 10 days, some symptoms. Even sometimes develop some post-COVID or long COVID. So this isolation, this COVID control room in continuation with all these patients, even after they recovered. The second course is fever. And I have some fascination of using favipiravir in these cases where fever is persisting. I don't know why. This is not evidence-based. This is, I can say, my friendship with Agam, or maybe my gut feeling, whatever it is you can say. So I am trying in such cases the favipiravir. I never combine the ivermectin, doxycycline. I know a lot of gastritis is there. People say, this is the usual comment from the people. So this is the second. The third thing is important when the dyspnea versus and the oxygen saturation goes down. This is the high time when, yes, we ask them for the oxygen support and of course the search for the hospital. So CMO registers their address and they keep on, the searching for the various hospital, L2 level hospital, L3. Now there is no L1 hospital, L2 level hospital where mostly oxygen is the main treatment, and L3 hospital where tertiary care, like King George Medical University. Our hospital is a more than 1,000 bedded. It is the largest probably COVID hospital in Uttar Pradesh, maybe in India also. So we have 1,100 COVID patient here right now, almost 99% of course bed occupancy. So this is the third. This is the third part. The fourth is the fever as well as the breathlessness. Now these are the patients to which I agree with Dr. Murali. I think this subset, I don't know, this is my personal classification, personalized UC class, subset of classification. These are the patients which require hospitalization and search or explore the possibility of using remdesivir by doing certain investigation. Yes, of course, we have to rule out whether patient is not having any renal disease or compromised liver function. Then, of course, but patient must be hospitalized. But what's happening now? This remdesivir, yes, I do agree with the 2020 remdesivir we used a lot. But nowadays, we are not satisfied. As Dr. Murali, we are also not satisfied. So Dr. Surya Kant now is against the remdesivir. So this is the situation of Uttar Pradesh and Dr. Surya Kant. And of course, ultimately, we are also believer that ultimately oxygen works and steroid works. Nothing works.
Fascinating, Dr. Surya Kant. The only thing, I sound like a broken record, but I would probably, being Agam's friend, start the favipiravir a little bit earlier than the 5th day. So I'm sorry I can't that, but maybe that's my only sort of, but fascinating the way you described it. I think That compartmentalization will help the audience a lot in thinking about patients. Wonderful. Anything that you want to add, Vijay or Krishna? Anything from your side?
Yeah, actually,
from my side,
completely.
Dr. Raja Dhar.
Yeah, Vijay, go
Please,
ahead.
yeah.
No,
So,
go ahead, Vijay.
Yeah. Rajabhai, so what I would, do is early treatment is very important in these kind of cases. I totally agree with you. Ivermectin seems to be, and doxy seems to be working really good. And I would stick to it. If coming to antiviral, if I want to add, so my choice would be remdesivir rather than, favipiravir. So looking at the scenario, whom I am going to pick is, so I will ask all my patients whom I am monitoring, in home isolation, all these mild cases. What I would tell them is, at least 3 times a day, check for 3 to 4 minutes walk test, and then, look for any evidence of desaturation. This is the time we can pick them. If they
Very
have
important.
desaturation, they are going to, crash at any moment. So for them, definitely the other drugs, probably, adding an antiviral and then adding a steroid would work wonders. So this is the additional thing I want to add to the panel.
Grand. Krishna, parting comment for this question?
Yes. And actually, after the brilliant explanation from Surya Kant sir, there's nothing that anyone can write further. But I will tell, I basically have never used favipiravir till date. And I classify it like this: 1 to 5, 6, 7, 8, 9, 4 days. Three segments there. 1 to 5 is 1. Okay, from day 6 to day 9 is 1. After day 9, that is the third category. So whatever should happen here. If it doesn't happen between 1 to 5, it should take place between 6 to 9. And if the patient is comfortable also, he should be observed beyond 9 days. This is the 3 important compartments. I would like to give this message to everyone hearing. So these 3 classifications we should see from the initiation. Like, I'm not feeling well is the first day of symptom. That is very important. I'm not feeling well. It could be anything: fever, cold, cough. So we should classify on these days wise. Then it will be easy for you to treat.
Right.
I think that's an extremely important point that Dr. Krishna has made, that the first symptom of feeling unwell, people, tend to ignore it. But when they know they've been a little unwell is when you really should start, the count. People unfortunately classify it from when they get fever or when they've lost the sense of smell. I think it should be just the first day of feeling unwell.
Right. I'll come to Dr. Surya Kant again. This is something that I don't know the answer to. I will seek your help. So, we've had a lot of epidemics before. There are respiratory viruses which are endemic in the environment, both in this country and elsewhere. And the STOIC study tells us about a reduction of duration of disease, a reduction of hospital visits, etc., like we discussed a little while ago. And we'll come back to the STOIC study in a minute. However, how come do you think with inhaled budesonide or inhaled steroids being there for such a long time, we have never thought about the use of inhaled corticosteroid in any of the viral respiratory epidemics that have happened before, be that influenza, be that SARS, MERS, etc. All of this has been around for a long time. We've never actually thought about it. Do you think that this is something which is peculiar to COVID? Do you think it is actually replicable for other respiratory viruses which are endemic in the environment? Or do you think it's class specific to COVID, Dr. Surya Kant?
Actually, I think they are, of course, they can be subjected, they can be extrapolated for all other respiratory, of course, viral infection also. The question is why they came in for the, of course, COVID pandemic. Why? Because other SARS, MERS, or other influenza and ongoing illnesses, and every year we are facing a lot of problem of influenza. Now, why didn't we explore this for these illnesses? The simple answer is that this time, in a very short span of time, high morbidity and high mortality, and of course, pan-global presence, these are the 3 regions which have, of course, focused a new repurposing of the drugs. You see, can you see this? How many repurposing of drugs have you done in 14 months? Starting from hydroxychloroquine, so many drugs, including the anti-HIV drugs, any antivirus drug that have been tried, repurposed. Anti-helminthic have been repurposed. Antibacterial, doxycycline, azithromycin, they have been repurposed. And still this process is going on. Desperately we are going on. And by optimism, we are going on. Kuch to mil jaye, kuch to aasha milega, a ray of hope. So I think this is the region, but I think we can extrapolate and we can also explore the use of inhaled corticosteroids for other. Because you see, nose and throat, these are the gateway of lungs.
Sure.
And if you can block here any respiratory infection or any respiratory viral infection, it will be a great help for the patient to control, to check the further progress of the disease. So I think we have to explore, we have to extrapolate, and we have to use in other also. This is my personal opinion.
Sure, that's exciting, isn't it? So the fact that maybe going forward, this is, I'm sure, not the last pandemic or the epidemic we are having.
Yes.
Many more. So it's exciting to hypothesize that this is a drug which is going to work even going forward in other respiratory viral infections. Anyone else on the panel have
one point?
Krishna, yeah, please.
1 point. See, it's very important point. Let us go by basics. We all know that steroids are working brilliant here. And we also know that steroids are strong anti-inflammatories. You can take an example of putting a steroid eye drop, steroid ear drops, steroid cream applications to any of the allergic skin rashes. You can think of anything. So steroid is potent anti-inflammatory. With this inhalation is giving you a steroid paint to your lungs inside. If it's a steroid paint you are covering, if you are giving your lungs a cover of steroid paint, if that is helpful, you should go ahead. Why shouldn't you? And one more point is, budesonide is lipid soluble. Budesonide gets soluble easily compared to other steroids. And this, I'm not telling, this is the GSK study this is. So this lipid soluble will easily get absorbed by the membranes. I'm not disclaiming that other fluticasone or anything else. But this is proven that budesonide is lipid soluble and easily absorbed by the membranes. Sure. So this could be one more thing to attribute that, yes, we should go ahead with this.
Grand. Thank you, Krishna. Agam has a point. Agam.
See, this particular disease or this particular virus has a typical capacity to play with your immune system. I have not seen this kind of immune behaviors with other viruses. You know, the way I look at it, suppose if I go to garden and there is a pollen exposure and I get asthma attack, the asthma severity does not depend on the quantum of pollen. It depends on the immune reaction that my body gets. Similarly, with this SARS, I personally believe this virus is not really very bad virus, but this virus has a potential to stimulate immunity in such a way that patients go into hyperimmune phase to cytokine phase, and the cytokine storms. You know, most of the complications and mortalities, etc., that we are seeing are not because of viremic phase. There is hardly any secondary infection. There is hardly any multi-system involvement with virus in viremic phase. All this thing happen in the cytokine phase, and hence these anti-inflammatory drugs, steroids, are working here. I don't think I would have ever thought I would have thought about using it in say for that H1N1 pandemic, etc., where cough was never a big problem that time. I think there is a different pathophysiology that we are talking about. Of course, it would be worth understanding its role, and as you rightly mentioned in your study, it did not have any impact on viral load. Logical, understandable. That means it is not actually antiviral drug. It is actually anti-inflammatory drug and taking care of inflammation. That's what is my understanding.
Sure. So, Agam, do you think this is class specific then? Your thinking is that, do you think this is something which is peculiar to COVID? The fact that you want to be
any viruses in future, if we get this kind of pandemics or outbreaks where it becomes immune reactions, probably this kind of drugs will have impact. Can anybody ever think of using steroids in infection? Did we ever think about it? Infections will be able to treat, steroids will be able to treat infections. We were always worried about using steroids. There may be infection, there may be secondary. We always kept on worrying about it. This is the first time we're using steroids upfront in majority of the cases. The minute patient gets hospitalized, he's given steroids, and if there is something which has shown for sure results, it is only steroids. So I think it is the potential of inducing inflammation that this virus has is very particular to this COVID too. That's my understanding.
Okay. So Murali, I'll come to you. I've got a question for you. You can have your comment and then answer the question that I'm going to ask you. So I was going to ask you about So I spoke about the cohort of asthma and even COPD patients being underrepresented, both in as far as incidence of COVID infection in these chronic disorders is concerned, and also patients having severe disease and getting hospitalized. So my question to you is, do you think this is just an effect of inhaled corticosteroid, or do you think there's anything to do with the Th2 immune response that we spoke about in the Chinese study? And there are other hypotheses which have come forth about asthma and COPD. Your thoughts? So comment about the previous question and then your thoughts, please.
So one of the things that worries me is when we keep talking about steroids, we must remember that the proof is with inhaled steroids in the mild phase and the early phase. We should not be using systemic steroids in the early phase. And I think that's something that this panel needs to highlight. Okay, the systemic steroids come in only later. When do we dive in with the systemic steroids is, I think Dr. Surya Kant and Dr. Agam have already pointed out. Fever is not coming down. The person is getting more breathless. The person is getting more breathless on walking, so we do the 6-minute walk and their oxygen drops. Those are the people, and maybe the markers are going up. Now, I would urge that we don't even do it for any one of these. We need a combination of two at least, so either a very, very high CT load or rising markers or clinical features. Two of these, give you the indication, yes, this person is going into the cytokine release syndrome. This is the person I'm going to start steroids. I wouldn't wait too long, but I wouldn't give it too early either. This time of 5 to 7 is really the overlap time between the two phases that Dr. Krishna spoke about, the viremic phase overlapping with the immune phase. And we don't really know who has gone into the immune phase and who is still in the viremic phase and who is in both. So I think it's very important to urge that please don't use steroids, because the reason I'm saying this, I see a lot of people who upfront day one, they come in with a diagnosis and somebody's already started high doses of steroids for them. So that's an important message I'd really like to give this panel to give everyone. The inhaled steroids, again, Raja, you can probably answer this question. You spoke about a class effect, and I think you were referring to the virus itself, but also we need to look at the class effect of the inhaled steroids. Is it a class effect of inhaled steroids? And the study you pointed to showing that fluticasone didn't have a benefit, systemic steroids did not have a benefit. It was only budesonide and cyclophosphamide that seemed to have a benefit, and to some extent mometasone. So is it a difference? And we must remember that fluticasone is really one of the most lipophilic of the steroids. It's far more lipophilic than budesonide is. So lipophilicity does not seem to be the only answer. There's a lot more than this when you come to it, and we need to dig into this to find out what the effect of budesonide is. Does it really, refer to a wide group of inhaled steroids, or is it peculiar to a few inhaled steroids? And I don't know enough about the pharmacology of these to tease out which is responsible for the benefits. Coming to your question, I think you're absolutely right. I think the inhaled steroids business did play a role in the lower representation of asthma and COPD in all this patients with moderate to severe COVID-19. But clearly, it's not only that. One is, of course, this tiny study you pointed out, the Th2, showing you less of the ACE receptors, for example. So you have less receptors to lock on to, you have less likelihood to progress to severe disease, or an alteration in the receptor and the effect on the airway and the airway vasculature. So far, we haven't spoken about the vasculature, and I think it's a very, very important part of the whole puzzle, that the vasculature plays a very, very important role in progressing from mild to moderate to severe disease. But clearly other things. Our patients with asthma and COPD have taken greater care of themselves. And this is, the reason I'd say this is a group who are not on steroids, interstitial lung disease, have also done peculiarly well. I thought our ICUs would be overwhelmed with our ILD patients, and they're not. I think this is because these people, fortunately, most of them have not come to see me in the outpatient. They've decided to stay away from hospital. They've kept themselves safe. And I think they've been a little more sensible than the general population. So it's multifactorial. It's the effect of the inhaled steroids. It is taking greater care of themselves, using the classic masking, hand sanitization, distancing, going to take their vaccination with less fear than the general population. So, and that is helping in the second wave. We're still seeing fewer of them in the second wave. And I think it is partly the Th2 theory that has really worked. And we know that that's true. The Th2 doesn't go down the infective pathway, but goes down the allergy pathway, to put it as simply as possible.
Sure. Thanks, Murali. That's a brilliant answer. Just to add to what you said, so one take-home message for the audience on there, which Murali repeated again and again, and other panel members have done too, is the fact that please don't start your patients on oral steroids on day 2, day 3, day 4 of illness. I think that's very, very important as a carry-home message. Do it after. Wait for the viral replicative phase to be over and drift into the inflammatory phase. Start the steroids early in the inflammatory phase, but not when viral replication is going on, when it's at its maximum. So I think that's an important carry-home message for all. I'll come to now you, Vijay. So I've got, again, your comment, and I have a question for you. I wanted to ask you, so we talked about the STOIC study briefly. I wanted to find out how relevant do you think in your practice, I know you see a lot of patients with COVID, how relevant, how much change is there going to be in your practice of patients with mild, moderate, very mild COVID, as far as prescriptions are concerned? How relevant is it to your practice? And the comment that you had about your previous question, please.
Right. See, here I totally agree with, Dr. Murali about whatever he has mentioned. So, majority of patients, of our patients who are, for the past decades, they are our patients. They even calling us and then inquiring about whether they can take vaccination or not. Whether the general population, they have neglected so much about vaccination. That's why we are in, worst phase during the second wave. So that's what the fear factor, what our patients had, and they have very, fragile lungs. They might land in severe COVID. That's one thing, that made them to keep themselves more, aware about the COVID infection, and then more they have restricted themselves to not getting this infection. This is what one point I want to add in addition to Dr. Murali.
Sure.
And coming to STOIC study, so I would try first, okay, what is happening in our experience, okay, after starting, okay, inhaled budesonide, okay, 800 twice daily looks like, little overdose for me, okay. But having said this, when we have started using, in our practice, it is both for, mild case and moderate case as well. And I think, most of our patients, okay, whom we think that, this patient might land in, might progress in mild to moderate disease. These are the cases which I would, recommend. Because another important thing, what I would suggest here is, because of over and rampant usage, okay, so after that recovery trial, everyone started using, steroids rampantly, particularly in India. Now there is a shortage of, methylprednisolone. There is shortage of even, Dexa in few hospitals. That's why I would, clinically categorize and look for, patients with risk factors, and then, start inhaled budesonide rather than, hitting everyone with, inhaled budesonide in mild category. That's what is my take, Dr. Raja.
Sure. No, makes a lot of sense, Vijay. I'll come to you, Dr. Surya Kant. You spoke about the 1100 odd patients in KGMC. I'm sure you also see a lot of patients with mild disease. So what's the UP take on use of inhaled budesonide, and how STOIC study has changed practice in UP and your practice?
Actually, till date, we have not started practicing except in a certain subset of groups. Of course, 4 or 5 experts in Lucknow and some other centers, maybe 20-25 pulmonologists in Uttar Pradesh, which have started. But in general, they have not come into the government protocol, number one. Of course, they have come in ICMR and AIMS protocol, but they have not come into the UP protocol, but they have been circulated. So recently we got this protocol, and this has been circulated, but we have to sensitize people because this is a new thing, and people are, the first impression is the inhalers are meant for the asthma. Why are you using an infection? So this is kind of thing that the steroid will increase the infection. You see the kind of thing the Murali is saying that yes, the steroid can of course increase the viremia, increase the viral replication. The people are thinking that the virus is also in the nose and upper throat. Why don't they increase? They are thinking that yes, they can increase the viral load here also. And of course, their query is not so simple. We have to explain that if you are saying that early oral steroid is not recommended, that it can increase the viral application, then why local this inhaled steroid, why this will not support and that is too in higher dose. The 800 microgram BD, that's a very high dose. So why this will not increase the local replication of virus? This question has to be answered to the people, which most of the people they are asking to be, especially the internist. Pulmonologist is not asking, especially the internist is asking this question. Dr. Surya Kant, we must know why this higher dose, why not medium dose? Medium dose can be accepted. Why this higher dose? They are apprehensive about this. Yes, they can increase the viral application. If any panelist can throw light, yes, I would love to listen it.
In fact, I was going to ask Raja the same question. Raja, do you know why they chose such a high dose?
Yeah,
It was a shock to me.
So Murali, so we are doing the STOIC 2 study, like we said. We've recruited about double the number of patients STOIC has actually recruited till now, but we're aiming for about 400 people, which shouldn't take long. So the reason, so I asked Mona and I asked Sanjay about why they chose this dose, and they've said that there is no rationale other than the fact that they wanted to maximize the effect of steroids, and they did not want to have multiple arms. So ideally what they would have done is they would have had an arm with 400, they would have had an arm with 800, an arm with 1600, and an arm which was bereft of without budesonide. However, if they had to choose one dose, they wanted to choose the maximum dose because they did not want to miss out on an effect. So that's the rationale. They wanted to do a quick study. They wanted to recruit patients and they wanted a positive result, which is why we are also doing 1600. But both Vijay's, your comment, Dr. Surya Kant's comment is valid. And I think going forward in our study, we have got some patients who are on 800, some on 1600, and hopefully we should be able to answer the question. So that's the answer. So you're right, 1600 is a high dose, but that's the only dose we recognize today as being effective. We don't know whether 800 or 400 is going to be effective one. So that's the answer. We'll move forward.
But Raja, the question, the second part of question of the people, MD medicine people, that is still unanswered. That if we think that steroid can increase the replication, why this local steroid will not increase the viral replication at that local site? Because viruses are entering through this. And you are giving these.
So Dr. Surya Kant, there was one study, and this is sort of in contrary to what STOIC found, but there's a basic science study that I quoted a little while ago, where it seems that the inhaled steroid actually depresses the ACE2 receptor. So the binding of it acts as an antiviral. So while viral replication was not reduced in STOIC, the reason Mona provides for that is that the number of patients they had was a very small number. And with that small number, it's difficult to show the antiviral effect. Our study is more likely to show reduction of viral replication because we have a larger number of patients there. So added to the anti-inflammatory effect that we are all talking about, inhaled steroid at that dose or maybe even a lower dose seems to have an antiviral effect, not different to what doxycycline has or azithromycin has, as we sort of hypothesize today. But this is hypothesis. But that's the hypothesis, and it's based on basic science that it seems to reduce the ACE2 receptor concentration at the site and hence prevents the SARS-CoV-2 to go and bind to the receptor when there's inhaled budesonide or inhaled cyclosonide there. So that's.
But the end point does not favor it. The viral load does not decrease in the study.
Yeah, so the hypothesis is that the number was small. If you look at the study, they actually had about 70 patients in the active arm. So 70 patients in the active arm, 70 patients in the control arm, and 70 they thought was too small a number to show reduction of viral replication. They stopped the study because they wanted to get the drug in. That's sort of bluntly put. And they stopped the study because their primary endpoint was met with those 70 patients. So that's why they stopped the patient. The aim was to actually recruit 300 patients when you combine the control and the active arm together. So hopefully we'll find out, but I don't have a definite answer. Yes, Murali.
And Dr. Raja,
I think the important point to make also, from the low risk of our asthma patients getting COVID-19 is the fact that they're not catching the infection. And that's very good evidence indirectly for the fact that the infectivity is reduced, not just the response to, after they get infected, the viral multiplication and so on. So they actually get less infection. And therefore, that's why Gina says, every patient with asthma, allergic rhinitis should stay on their basic treatment.
Sure.
Okay, because I think it definitely helps to reduce.
Very valid point. Yeah. Vijay, you had a point.
Yeah. Do we need to consider that there is no increase in viral load after treating with budesonide? Is that matters? One important thing. Second important thing, if we look into the study, okay, what happened was the sample collection was in home the sample collection was by self-sample given. Most of the patients, they have given the sample themselves. So how accurate they can, because yes, I have collected my sample at least 3-4 times during this pandemic. It is very tough. Okay. Very painful.
Sure.
Your comments, please.
So I think if you look at home care in the UK or in any European country, for instance, there has hardly ever been anything other than self-sample collection. So Vijay, the studies that you see in any condition based on domiciliary care is actually with patient collecting the sample. So you're comparing like with like, so you're not comparing eggs and apples, for instance, you're comparing like with like. All of it, you're absolutely right. It's painful. I wouldn't actually do it. You're a brave man, Vijay, to be able to collect it. I wouldn't manage to do it. But I think they are made of hard sterner stuff, and there's maybe no other way to do it. We cannot send people in the UK to people's homes to collect samples. It's not conceivable. So whenever we're doing a domiciliary study in Europe, it's all based on self-sample collection. And it is going to be as good as you get, really. So that's my comment. I don't think so. We are actually sending people to people's home to collect samples. So we'll see whether there's a difference or not. But
okay,
the
Raja bhai,
to do that. Yes,
Raja bhai.
And the first question was
I give IM to myself. I give IM to myself, both to deltoid or to gluteal. I take IM myself.
Leta kya IM mein? Wo to bata. What do you put there?
Krishna
this is a very good question. This is a very good question. No, IV I don't take myself. IV I don't take myself. There are other set of qualified people for that.
Yeah.
So other thing, coming to stoic study.
Yeah, Vijay.
Okay, Raja bhai.
Yeah, Vijay.
So there is no increase in viral load at the end. But also I think it is not significantly affecting the viral replication. It is not facilitating the viral replication.
Sure, absolutely. Very fair point. So I can see that Agam has finished his vada pav, even though it was hiding. I could see it. And then some liquid from underneath the table. So he's relaxed now.
Water bottle.
The next question. So,
I was thinking repeatedly.
No, Agam is admitting that it is quarter bottle.
So Agam bhai, I wanted to ask you similar lines to this question. 2 questions. One is the stoic study used a DPI, and second was the dose. So when you're doing this in your own clinical when you're going to do this in your own clinical practice, Agam, are you going to be using a DPI? Or would you think that the results would be the same with an MDI, with a spacer, or just with an MDI? And are you going to use the 1600 that all of us discussed just now? Or are you going to go say that's too high a dose? Let me go with the 800. The results will be the same with the 800. What is your message?
Kind of, yes. Anyway, I have been little more comfortable with DPIs than MDIs and spacers. So my personal preference, when a choice is given to me to choose a device, I would choose a DPI by default, and hence my preference would be DPI.
So Agam, my question was different. My question is, do you think the device matters at all, or do you think it's
yes, of course,
this condition?
Yes, of course. If anything that matters is device. If patient does not take it properly, it makes no sense.
For this purpose. For this purpose, for the stoic study.
For any purpose, if you want the drug to be delivered properly, its device is all that matters. And hence, probably my preference would be, and see, logically, if they've done some study on a particular device, and if I have a choice to choose, why would I choose something different? And when I like the device, so then I would go by the same device if the choice is given to me. When it comes to dosages, I would, to begin with, continue with the same dosages. If I don't see any side effects, which I otherwise anticipate, fungal infections, etc., because these patients are not asthmatic, these patients are not COPD, they're not used to taking it. We are doing a lot of telephonic consultations, and we may not be able to show them the right technique. So there may be limitations of this use. Of course, we are going to be using it for a shorter duration, but then I would keep all this in mind. And the experience would make us wiser. In some time, we would realize whether we need to give DPIs or we need to change to, spacers. or better drug delivery and less probably complications, I think I would be wiser in some time once we have a next meeting and once you give us your experience. I just blindly follow what you practice, so then I would do it.
Thank you, Agam. Thank you.
Raja bhai, one thing to add. Just
Krishna
one
bhai
thing to
and
add.
then Murali. Yeah, Krishna
One
bhai.
thing to add.
Yeah,
See,
please.
what is important is the drug should get delivered properly and enter your lungs. That is important. Let it enter, however. If it is DPI, MDI, or it's with a baby mask,
Nebulizer.
or whether it is a nebulizer, I don't care. My ultimate job is to enter there. So imagine a person having a poor inhaling capacity. His inspiratory volume is very low, and he is unable to take DPA there properly. So you cannot exclude that person from the benefit of this particular budesonide study just because he is unable to take a DPA.
Sure.
So you can change your plans there with a nebulization or with a spacer whatsoever. Ultimately, our result is it should go inside. That's it.
Sure. Fair. Absolutely fair point. Murali.
I completely agree with what Krishna said with this caveat. When you look at the CTs of patients with COVID-19, the disease which is classical is peripheral. It's, these most peripheral areas of the lung. If you see a lot of central disease which follows the bronchi, that doesn't really look like COVID-19. So you want it to get as deep into the lungs as possible. In fact, I'm very, very puzzled why a DPI was chosen. If you go by most of the British studies, including, for example, in recovery using dexamethasone, is it for ease of use, for low cost? It's not that it's more effective or, there are other good scientific reasons for it. Very often is what is easily available in every place around the world. Because remember, recovery was a WHO-sponsored trial. They wanted to reach everywhere. They wanted to be cheap. My feeling is that, they've gone with things you mentioned. It's easy to teach people how to use a DPI. However, for me, extrapolating from what we know, I think we should be using something which reaches a deeper air. And Agam is very fond of DPIs. I'm very fond of MDIs with spacer. Now, it's a little more difficult to get people to use MDIs with spacer during a pandemic as you get on a video conference. So we've got the wonderful SynchroBreathe, which is going to help us. And a lot of my patients are actually on SynchroBreathe. Unfortunately, you have to use an ICS-LABA combination. And I don't like to use very high doses. So Raja, what you said, I tend to use slightly lower doses where, I'm worried about the patient. I then tend to use the 800 twice a day. When I'm not very worried, as Dr. Vijaykumar was saying, these are not the high risk patients. I'm happy to use a lower dose and I'm happy to use a SynchroBreathe, or when a patient is willing to use it, I use an inhaler with a spacer because I think that's very, very important. But during the conversation, it was very odd. I've forgotten the name of the PI on the STOIC study. He said, don't even gargle after using it. It's like he wants a whole lot of steroid to stay in the throat. That to me was a little odd. We normally advise people to gargle, get it out. He wants it to work locally also. And, I'm not sure about the logic behind it. The other thing, of course, is Vaishali was asking me, the sales of, nebulizers have gone up hugely in the second wave. Is there a reason for that? And I have absolutely no idea. Clearly, people are using what they can get because right now it's almost impossible to get DPI budesonide.
And it's catching on to straws too, Murali. I think it's a question of thinking if the inhaled steroid works at X dose, maybe it will work even better at Y dose, which is higher than the X dose. I think that's clutching on to straws. We've had a bad pandemic and that's probably a reflection of it. I'll quickly sort of try and wrap things up in the next 5 minutes so that we can take some audience questions. And if we can have the audience questions in the chat box, I would be obliged. So if the admin team could put the questions in the chat box for me, I would be really obliged. So I wanted to ask, I'll come to Vijay next. So Vijay, there's something interesting which comes out from the National Health Service in the UK as far as their recommendation of inhaled budesonide is concerned. The recommendation is for patients above the age of 65 or patients above the age of 50 with comorbidities. Now, if you look at the current pandemic, and I think this was something that Murali was mentioning a little while ago, we've got a younger population for the second wave, right? We've got patients with younger age actually getting worse, getting admitted, getting sort of ventilated, and those numbers are not few. So if we try to replicate that in our population, I think we would be going the wrong path. So would you think you would actually think about doing it for the higher risk population? Or do you think you would actually want to do it for people across age groups, irrespective, above the age of 18, that's adults, across age groups? What is your take, Vijay?
So my take is, so I would like to classify these patients who are with comorbids, who are young, who have a tendency to progress, something like exercise-induced desaturation, or something like morbid obese. Okay, and those who have additional comorbids like diabetes, probably uncontrolled diabetes, hypertension, history of acute coronary syndrome at a younger age. These are the patient populations which I would recommend, rather than we cannot, in this pandemic, we cannot already, you have discussed that, there is a huge non-availability of budesonide in the market. So for that reason, better at least, I would like to, hear from all other, experts as well. So whom we have to really, give this molecule, and then we have to, at the end of this 1 hour session, we must give our audience a proper guidelines so that there is no misuse of the budesonide.
Yeah. So let me give you my 2 penny worth, and then we'll go to Krishna. I can see Krishna unmuting there, so I'll go to Krishna Bhai next. But so my 2 penny worth would be that I would actually use it early in the disease process, and I would actually use it in patients with mild disease, and I would use it across age groups. I think we have seen quite often that it's not always the patients with uncontrolled comorbidities. It's not always the elderly who get worse. And it's difficult, even with all your markers and your CT scans, to predict who is going to move from mild disease to moderate to severe disease. And often post day 7, we get a nasty surprise with patients who were relatively well between day 4 to day 7, suddenly spiking a fever or suddenly becoming hypoxic. Hence, I would not reserve this drug for individuals across comorbidities or across elderly age groups, but give it to people who have symptoms, as long as the patient presents to me early. So I think that's more crucial as compared to waiting for the patient to have more symptoms and then prescribe the drug. That's my take, but I would like to hear what Krishna Bhai has to say.
Raja Bhai, actually, I strongly support your views here, and I am of the same opinion. Till date, I haven't started much of this, but now I would feel that if you have to hit it hard, hit it at the beginning. So you need to hit it when it is the perfect time. Whatever you do it at the earliest, and for no reason. See, if budesonide can be administered for a restrictive airway disease anywhere to any kind of population, so it is not something which should have age. It's not a age restricted molecule. So a person is given budesonide only if he is 50 years above for obstructive airway disease. It's not like that. So because budesonide is already a tried molecule in the mankind with different age group populations, so it is not something that you can tell, no, it is forbidden, I cannot use this in this population. So I completely agree with you. Start it early and get a good effect very early.
Sure. Thank you. So I'll quickly go through a couple of molecules. We're waiting for questions to appear, but quickly go through a couple of other drugs. So I wanted to ask you first, Murali. So nitric oxide. So I saw very exciting data both for prophylaxis and for treatment of mild disease with nitric oxide, so nasal nitric oxide. Any thoughts, or any deoxyglucose? I think you spoke about briefly. Any comments?
Actually, that's only what I've been reading. Clearly, we don't have access to it.
Sure.
We don't. But it looks exciting and it makes sense. SARS epidemic, where they found that using nasal nitric oxide actually reduced the viral load there. I think my internet connection, am I having problems?
So we lost you for a couple of seconds, but I can hear you loud and clear now.
Yeah. So basically the, nasal nitric oxide seems to work to reduce the viral load. It reduces viral replication. It seems to have definite benefits. How exactly it does that is not very clear, but it's thought that nitric oxide has a wide antimicrobial spectrum, an extremely wide antimicrobial spectrum. So, it's actually surprising that we haven't used it more often. It's a very simple thing to use. You use an NO donor, which just a few squirts in the nostrils. I'm just worried about what is the long-term implication of this. When you know that NO is a vasodilator, reduces, increasing the amount of vascularity there. If you use it too often in India, as you just said, if a little is good, more is better, and too much is best. I'm wondering people will be squirting this in their nostrils all day and end up with problems in the future. Maybe huge nasal polyps, which the ENT surgeons will all handling. So that's my worry. But so far evidence seems to be good. Most of the data comes from a single company, Sanitize, who are in the business of NO. So that again is a little source of worry for me.
Yeah, sure. So come to you, Dr. Surya Kant. Dr. Surya Kant, your thoughts about these expensive MABs which are coming in? They're tongue twisters. I'll try and pronounce them. Bamlavimab, right, which is acetamivir. So the name, I'm not very good at pronouncing them.
So Raja, give me only a few days time. So I used to, of course, simplicize, indigenize all these tongue twister names. For example, I give you a short example. For example, when Remdesivir came, I said Ram Desi Veer. राम कौन है? भगवान राम. कौन से हैं अपने इंडियन? देसी है ना, तो देसी हैं. कैसे थे? वीर थे कि नहीं? धनुष्मान लिए रहते थे कि नहीं? So don't worry, I will simplify them also and will come with you. So of course they are very promising. Of course the cost is a very good factor, but you see especially I'm commenting on that cocktail therapy 2 days back, which have been of course approved by US FDA. And then, of course, that cocktail therapy appears to be promising. I talked to a few doctors in that UK and US. They are also very much supportive. The only limiting factor is the cost. But if you see in this country, now this is not a poor country now. We have so many Ambanis and Anis here also, so they can pay anything. So for those, they are asking or they are demanding anything to treat them. So I think they are the wonderful alternative, and definitely we have to use. And then, of course, ultimately, time will tell whether this fate happens like Remdesivir or fate happens like a good one. So that time will tell.
Thank you. Yeah, thank you.
Kind interruption. So kind interruption.
So Raja, thank you.
Away from the topic.
Raja, thank you very much for. I have to leave for some urgent call. So please excuse me. I think you continue. I enjoyed a lot, but excuse me for. Thank you very much.
Surya Kant sir, 1 second before you leave. Listen to this. We have broken our own record. 1520 was our previous logins history. This is 1643.
Oh, great! Congratulations. Great. Thank you very much. Namaste.
Yes,
Namaste.
yes.
Namaste. Thank you, Dr. Surya Kant. Very grateful for your presence. Thank you very much.
Okay.
Thank you.
Bye, Dr. Surya Kant.
Yeah. Hi, Dr. Murali. Yeah.
So Agam, I have got one last question. Where is Agam gone? Yeah, he's there. So I wanted to ask you. So there's this thing about prophylaxis. Healthcare workers, frontline workers throughout the world are looking for some sort of prophylaxis. We've gone through this HCQS azithromycin story. We've done the ivermectin story, the studies on favipiravir which have failed. Do you think budesonide might have a problem in prophylaxis? Do you think taking inhaled glucocorticoids, inhaled steroids,
Not really,
actually prevent the disease?
Again, with my limited knowledge and with my limited understanding, I feel this budesonide is working only as anti-inflammatory drug, even in the airways.
Okay.
Now, if there is no inflammation, it cannot work. It's like you are asking me whether you can use this, inhalers for asthma prevention. If there is no spasm and no inflammation, there is no bronchodilation, no anti-inflammatory effects. So, to my understanding, probably these drugs may not have any prophylactic role.
Okay. Right. So I think that's my questions. Thank you very much. I really enjoyed that session. I'll take some questions. There's a lot of questions actually. So Krishna Bhai spoke about the 1640 odd people. Out of that 1640 odd people, at least 10% have asked questions. So that's a lot of questions. In the next 10 minutes, I'll take a few of them. Let me start off with Krishna Bhai. So Krishna Bhai, there's a question which talks about how long would you use the steroid for? So one question. Let's start with that one. How long is the steroid?
This is regarding budesonide?
Yeah, budesonide in COVID. That's the question.
Inhaled budesonide.
Yeah.
Okay, fine. I got it. So now this should be used in the inflammatory phase only, I believe.
Okay.
But as Dr. Murali sir rightly said, systemic steroids in the later phase, inhaled steroids in the early phase.
Yeah.
So 1 to 5.
So, okay. So you think it should be sort of stopped after 5 days? Is that what we're saying? Or do you think it should be?
No. I told initiate it between 1 to 5 days.
Yeah. And for how
and
long?
You can continue it. I believe you should continue it at least for 15 days.
Yeah. So that's what, bang on. So that's what the STOIC study did. They continued for a period of 2 weeks, which is what we are doing for our study. There's another question which talks about the use of this drug in children. So that's especially relevant. I'll take that to Murali. Murali, are you there? Yeah, so I cannot see Murali. So let me put that question to Agam. Agam, would you sort of, with the second wave, with the oncoming third wave, the focus is now on kids below 18. So maybe a quick comment.
He's there.
And then
all difficult questions for him, we have decided already.
So Murali, would you think you would extrapolate the evidence of STOIC to people below the age of 18?
No, I wouldn't. I think we need to wait for evidence. It's a little dicey. Now we don't even have evidence for the vaccines below 18 yet.
Yeah.
I mean, we are now getting into it. One of the studies we're doing is looking at the 12 to 18 group. But I think that's a dangerous precedent to, automatically explain. I always, children are a different animal. They're not like us. So you can't extrapolate the same data. No, I don't. I wouldn't do it. Fortunately, I just passed them on to my pediatric pulmonology colleague, so I don't have to take that decision.
So there's another interesting question. I'll put this to Agam. Agam, in this second phase, desaturation is occurring early, and it is difficult for patients to calculate the first day of the illness. So sometimes waiting for 7 days to start steroids may worsen the situation. That's a comment. I know we discussed this, but maybe a comment from you, and then maybe from Vijay, about what you think is the right time even in the second wave.
Perfect. The right time to start steroid would be beginning of cytokine phase, if at all. Now, it may be difficult for you to calculate days. And this cytokine phase does not follow your date formula. It doesn't know it's already 7 days and I have to start. It doesn't happen that way. You have to suspect the cytokine stage coming in. So whenever there is a new fever coming in, whenever there is a new cough coming in, whenever there is any new development coming in, whenever there is fall in saturation going in, that is the time cytokine phase starts. And as I told you in my limited understanding, cytokine phase beginning could vary. It could begin right with the viremic phase. It could come up on 3 to 5 days. It could come up 5 to 7 days. It may come up even later. Now I'm seeing in second wave, 9th and 10th day is what I'm seeing cytokine phase coming in. So there is no date duration. There is no day-wise duration. It is when cytokine phase begins, you have to start steroid. Thank you.
Grand. And anything to add, Vijay? Vijay, is there anything that you want to add?
By any chance, if we can avoid in first 1 week, it is brilliant. So adding steroids, oral steroids, okay, in first week, I am doing my best to avoid, but exceptions are desaturations, high rise in inflammatory markers, and patient overall general condition is very bad.
Grand. I think that summarizes the carry home message. I mean, that's my carry home message too. So I think that's very important carry home message, Vijay, and thanks for pointing it out nicely.
I think the questioner had an important point also, Raja, that you can't sometimes really know which is the start date.
Yeah.
Okay, so you have to go by the other factors. I've just got a message as we are speaking from a cousin's husband who says after 4 days of no fever, now he's started to spike a little fever. That's a warning symptom that he's in the previous phase. So those are the kind of things you look at. You have to follow them carefully to get this clue.
Sure. There's another question which is very interesting. So I'll take that to Krishna Bhai. So Krishna Bhai, there's a question about what about combining inhaled steroids with oral steroids? So that's sort of too much of a good thing. So what are your comments? I think we discussed that a little while ago. What is your comment?
When I take my wife outside with me, I will not take my lover with me. When I take my girlfriend with me, I will not take my wife with me. So I believe that you started initially with inhaled corticosteroid, and later if you are in a phase where, as Agam rightly mentioned, the cytokine storm, there when you have introduced systemic steroids, then inhaled steroids could be continued or could not be.
I would draw.
I'm a little worried about this comment on Mother's Day, My attitude would be to continue the inhaled steroids, at least for the first couple of weeks, while I introduce the systemic steroids. I think they have very different effects. You have a very potent steroid on the surface where the problem at least started. And therefore, you can add this on. It's a drop in the ocean of systemic steroids anyway. So that's perfectly okay to continue both.
Yeah.
You're to everybody, Dr. Krishna. So.
So I think both points of view are right. I think you wouldn't sort of message for the audience is you wouldn't actually combine the oral steroids with the inhaled steroid simply because you want to do it. So early on, when you're starting the inhaled steroid, you should not start the oral steroids like everyone else in the panel has said.
Yes,
but if you started the oral steroids and the patient has got worse and you have for indications that were pointed out by Vijay a little while ago, start oral steroids. This requirement to stop the inhaled steroids at the time. I think that's what we are seeing as a part of the panel. So that's an important question. Thanks to the person who's asked that question. Lots of other questions. Dr. Krishna, how much longer can we continue? Tell me.
Yeah, you can continue because I am sitting. You can continue till tomorrow.
Tomorrow, no.
No, because I am sitting here. Nobody will stop.
Okay.
I am the one to stop, and I myself am sitting here.
There's a lot of questions which are not on inhaled budesonide. There's a lot of questions about severe disease, about remdesivir, which I am not taking. Let me see questions.
Meanwhile, I want to add a point.
Yeah,
Raja.
please, Vijay.
Right. See, I was looking for some literature evidence of this, inhaled NVO or for nitric oxide. So, doing this pranayama or humming, just it is from Nature Journal published that doing that omkara or humming itself will produce lot of intrinsic. I have written an article in Deccan Chronicle yesterday about the same. So it generates in nitric oxide that is protective against these viral illnesses. So that's what I want to add it.
Yeah, grand. Brilliant point. Thanks, Vijay. We've got a very ingenious audience. Indians by nature are ingenious. I'll come to you with this question, Agam, because you are also very ingenious. There's a question about intranasal steroids. So do we think intranasal steroids would work well? After all, you take the nasopharyngeal swab. That's where the virus lies. We're talking about topical application. So do you think we should use intranasal steroids instead of inhaled steroids with inhaled steroids? We don't know. But what's your hypothesis?
No comment. Dr. Murali Mohan.
I'll paraphrase slightly and say no evidence, but extrapolating from the fact that our asthma, allergic rhinitis didn't have too many problems, I would say happily use it. We've seen this in the past also. We don't stop the intranasal steroids in patients because they have a cold or anything. We just continue it. And actually those who persist to their treatment seem to get less cold. So I'd say go ahead and use it. Don't stop it, but don't use it instead of an inhaled steroid. I think you need to use both perhaps.
Thanks.
No evidence. Absolutely no evidence.
No evidence. Correct. So I want to read this. This is Puneet, and this is actually touched a chord. A lot of us have had experience similar to this with families, etc. So I want to read this, and it will stay with us and should stay with the audience. My family was COVID positive. I started nebulization with Budecort 0.5 milligram thrice daily. So that's 1.5 milligrams of budesonide a day, similar to what happened in the STOIC study. From day 1 or day 2, my father was diabetic, coronary artery disease with LVF 30%. He landed in severe oral candidiasis on day 1. That is when it was noticed. Even after proper oral gargle, after Budecort, nebules, respules, oral candidiasis, total suppressed appetite for a few days. And my father landed in sudden desaturation with increased inflammatory markers on day 13. That is second storm. At last, I lost him. So my point is, should we add on inhaled budesonide in immunocompromised or diabetic patients? Like I said, condolences for you, Dr. Puneet. I think that's a story which is tragic. I don't think we can actually say that it was the inhaled steroid alone, which was responsible for this debacle. I think your father had multiple comorbidities. Obviously, there's a strong carry-home message in what you say for us as faculty and for the audience. The fact that inhaled steroids do have local adverse effects, and we should watch out for these adverse effects. They shouldn't be used willy-nilly, like Vijay was saying a little while ago, and they should be used with some forethought, and we should look out for complications when you use drugs like this. I think that's very, very important, a point that comes out from this tragic story that you've actually told us. So any comments, anything that you want to add, Murali?
No, I mean, that is really a tragic story, and it's a tragedy that's being repeated across the country, across the world. It's very difficult to get messages like this. It's really heartbreaking. All I'd say is, yes, be very careful. Steroids are not, inhaled or systemic, are not things you treat lightly, you use lightly. It's not just candidiasis. You also worry about mucormycosis. We're hearing more and more stories of mucormycosis. We are seeing these, mucormycosis, and that's far deadlier than candida. We can handle candida still, unless you get a bad candida viremia with one of the multi-drug resistant candids. But mucormycosis is so difficult to handle. So my point is that I think use them cautiously, bring them down as soon as you can. But Raja, I completely agree with you. That tragedy was largely, it's not a single factor. I think it was multiple factors, comorbidities, which we know about. As you get older, as you have more comorbidities, these things get... A good friend's mother passed away this morning, unfortunately, on Mother's Day, a fellow pulmonologist. So these things are going to happen, and all the more reason we need to bring this pandemic to an end as soon as possible. And all the more reason prevention is far better than any cure. I think we lost
Dr. Raja lost his connection.
Raja, perfect time he entered and perfect time he left, it seems.
I actually think Raja took proactive action to bring this to a close.
And the questions are all with him only because he's the moderator. So every question is with him only.
Krishna, you may conclude.
Yeah. Okay, fine. Raja Bhai, okay. In your absence, I'm going ahead with concluding this. So I would give it to Murali Mohan sir. Now, initially, sir, please tell us 5 lines of take-home message from here, because we have all talked about it. We have summarized few things regarding let it be oral steroid or inhaled steroid or systemic IV or whatever. The take-home 5-line message is very important, as you observed during the entire panel discussion, sir. Please go ahead, summarizing it.
So, first point is something you brought out. Use drugs judiciously. You need not send away a patient without any treatment. Placebo effects work in the right hands. But again, don't lie to patients that something is going to be effective when we don't have evidence of it. Share the evidence with them and tell them, look, we are giving you this. It may or may not work. Second, Raja's back. Sorry. Raja, we are summarizing 5 key points.
Sure.
Our chairman decided...
Because we couldn't contact you, so we thought...
So Krishna Bhai, great thought. It was probably a signal for me to say, please shut up. And that's why I disappeared. Please go ahead.
Sir, go ahead, sir.
Be careful with choice of drugs. Rely on the evidence, but use your art of medicine along with it. Don't use that as an excuse to bypass the evidence completely. Second point, inhale steroids early, systemic steroids late. Use systemic steroids judiciously, and a good cutoff point for introduction of systemic steroids is between day 5 and day 7. If the patient continues to spike temperature, if the patient starts showing you deterioration in terms of hypoxia at rest or on exertion, and if the inflammatory markers are suddenly rising. 3, the role of intranasal steroids is not very clear. Be careful about using it, but it looks like it may not have that bad a problem. 4, classify your patients. A lot of your patients are going to get better by themselves. You don't need to interfere. You just need to keep an eye on them. But be alert for a rapid deterioration. And that's when you need to intervene. You have a choice of intervening early with favipiravir, as Raja and Agam feel, or you say, I don't want to give that time for favipiravir, as Vijay and I feel, and we need to move on to remdesivir. That is an individual choice you have to make. And I think that will be guided largely by your own experience with using these drugs. And I think looking at the variants in different parts of the country, we are going to have to rely more and more on local experience. I think my experience is not going to be the same as Raja's experience or Agam's experience. So you have to rely on your own experience to some extent, guided by the evidence already present. And last of all, hopefully we will be able to get over this pandemic. But the thing that we've not discussed, but which underlies every single discussion, is prevention is better than cure. Please encourage yourself, your family members, your patients, and the general public to use a mask, hand sanitize, and maintain physical distancing from others. Very, very important, because prevention is 100 times better than cure. 5 points.
Thanks, Murali. Brilliant. I mean, that's absolutely
Brilliant.
पहले ये बोल दिया होता तो सीएमई का ही जरूरत नहीं था.
Agam, now you have to talk about 10 more points after what Murali has said to finish off the meeting. That's your
only
challenge.
1 point to make. I was just looking at the prescription that I received from Krishna. Krishna may be sitting in a place. I am known because of Bombay, and there are some people, the place is known because of him. I never knew about Davangere before I met Krishna, and Davangere is known because of Krishna. That's how it goes. And Krishna is doing a lot of teleconsultation. So there was one patient who came to me for second opinion. He said, I went to Krishna sir and I asked him, give me some best medicine for COVID-19. And Krishna sir has given me this prescription. And I saw in the prescription, he's written Fevicol. And he says, apply it on your bottom and sit at home. That's the only way to stay away from COVID-19. So that's what Krishna is all about. Last 1.5 years has been very, very, educative. We got opportunity to learn a lot of things. We've realized COVID, it's a game of snake and ladder kind. Certain medicines came up, then went down and came up again and went down again. And then probably steroids are the molecule which kind of have persistently shown improvement. And now we have the evidence for inhaled steroid as well. I'm really excited with this study, and I'm really looking forward to put a lot of my patients on this. I think I would consider this kind of treatment for all mild to moderate, COVID patients who I'm managing at home. And probably next 3 to 6 months, we would be wiser. Thank you very much.
Thanks, Agam. And something else which is thought-provoking, we keep talking about oral steroids. If this disease indeed prevents progression and hospitalization, it might be like the asthma story. Giving the inhaled steroid early might prevent you from going on to oral steroids in the first place. It might be a similar story again. So your thoughts,
and I was excited. Raja,
Vijay,
that remdesivir is registered with sublingual preparations. Are you aware of that?
Yeah, I've seen the FDA. Yes, I've seen it on the FDA site.
I saw it yesterday only. Sublingual remdesivir, imagine. Cool, good.
Yeah. Vijay bhai.
Important to emphasize that it doesn't get absorbed, given through orally. So that's odd, Sublingual is okay, but oral is not okay.
Mm. Raja bhai and another, panelists. Thank you for having me here. Okay, Krishna Anna, thank you. So my point is, we have to carefully select our patients before, adding to any medication, whatever we are adding. Carefully, every patient behaves in a different manner. Be, patient-centric rather than, non-centric. That's what I want to add. And to the entire forum, and then to the, whoever, listening to this, one important point to add is vaccinate. If you are really scared of vaccination, don't get delayed. It is quite safe. Vaccinate with either vaccine, Covaxin or Covishield at the earliest, so that we can prevent the disease.
Thanks, thank you very much. So I really enjoyed doing this. I'll hand over to Krishna bhai in a minute for the concluding remarks and his take-home message. But I really enjoyed doing this. Thank you, CCI. Thank you, Krishna bhai and Vijay. And thank you, Murali and Agam, for this very, very lively discussion. I hope the audience got something out of it. Thank you to the audience for being there and asking so many questions. I'm sorry we could not answer all those questions because unlike Krishna Bhai, I think we need our dinner. He was agreeable to being there for all night, but I feel hungry. But thank you. Brilliant discussion. And do remember, I think, important, this phenotyping question that we started off with, who is for what, whom to treat, whom not to treat is still an open question. And I think what Murali said is very relevant. You need to do it according to your local requirements, your own city, your own state is important. And you need to have your own algorithm in your own head. It will not be vastly different to what the national guidelines or the international guidelines are, but it will be tailor-made to your particular region to a certain extent. And that's important to discover because now we are waiting for the third wave even before the second wave has plateaued, at least in Bengal. So it's sort of morbid times. It's going to continue to remain morbid times for some time, I'm sure. So it needs our individual collective intellects to try and get over this pandemic. So thank you very much, and over to Krishna Bhai for the concluding remarks.
My concluding remark is in one line, that is just hear and listen and believe in all what my panelists told. And
I want to share a joke, but once we go offline.
Okay. So one important thing before leaving, Happy Mother's Day to every mother in the world.
Yes.
Happy Mother's Day to every mother in the world. We are nothing without her. So salutes to her. So I think we can conclude. So thank you, everyone.
Yes.
Thank you.
I also must thank on behalf of all panelists to Raja. Raja, you conducted so well and you make it so lively. Last 2 hours, I think it was very, you kept all of us busy. Thank you very much for doing it so well. I must thank CIPLA for giving me the opportunity and all of us for connecting to those 1,500, 1,600 people on this Sunday evening. Thank you very much.
Thank you, Dr. Raja. It was absolutely brilliant moderation. And having Murali Dhar sir in the panel, it is a clever decision by me always to pass on the difficult questions to him. So only I take him.
And then we are extremely grateful to you for putting that, curtain there because it scares me. Your background really scares me.
But Raja Bhai, excellent moderation. Huh? I cannot find anyone else. No replacement, non-replaceable. And having Agam there is adding like humor. So whenever Agam is there, you are adding humor to the show.
Oh, I'm always there.
Sheer brilliance in his knowledge. So it was all fantastic. Thank you so much, everyone. Thanks, audience. Industry Hit was created 15 days ago with 1520 logins. We have broke our own record with 1643 logins. Thanks for the faith in CCI. Thank you so much, everyone. Bye-bye, everyone. Good night. Good night.